Dr. Greg Doerr. I practice in New Jersey, and right now we're going to give a little bit of a discussion on some knee injuries. Basically, one of the most common things that we'll see associated with knees are things like patellar tracking disorders. So, an easy things that you're going to see associated with our patients with tracking disorders is usually they may experience pain, obviously, with steps, going up or down stairs, running and jumping, things along those lines. But one of the things that you also see, which is interesting, is if they're immobile for too long a period of time, possibly sitting in a chair, or maybe they're on an airplane for 2 or 3 hours, their knee just gets generally an achy sensation, but they really can't pinpoint exactly where it comes from. So one of the easy things to do to actually figure that out is doing things like squat tests, okay? So while we have our patient here, she may be going down a stair and says, I get pain, but we might not have steps available to us in our office, so we might do something like a simple squat. So we have our patient go into a squat position, and she can generally tell us, okay, I have pain in a certain area of my knee. Come on up. Now, if she's got, and in this case, we'll assume that our patient either has lateral knee pain or maybe she's got some medial, with tracking disorders, you could get literally pain on either side of the kneecap. Even if it's a laterally tracking knee, it doesn't really make a difference. The pain situation can happen almost anywhere around the kneecap. But the big thing is what's happening associated with our evaluation. So in particular, when we're looking at a knee, there's several things we want to check for. Mechanics, obviously either with the patella or associated with tibial torsion, which is another major issue that we'll see with patellar mechanics. So she goes down, she says, I have pain. We're going to go down, one more squat, and she's got an ouch. All right, she comes back in, and she says, I have medial knee pain. Some of the tests that we want to check for associated with directional problems with the knee is we can start by literally just blocking lateral patellar tracking. One of those things is I don't push on the patella sitting right here. I'm not pushing on the patella. All I'm doing is placing my thumb right to the lateral border of the patella, and we'll have our patient redo her squat. Again, all we're doing in this situation is preventing the patella from tracking laterally, not pushing it medially. If the patient says, yeah, I feel a lot better with that, we're set. We already know that we have a lateral tracking problem. If she's saying not really a big change, I still have a significant amount of pain, we're going to start checking for some other things. We may check for lateral superior, lateral inferior. We can check for a general patellar unloading by just literally grabbing some of that skin and pulling up. And one of the major ones that we see associated with this is actually tibial torsion. In that situation, what we're going to do, the majority of time when we see tibial torsion involved, it's going to be internal tibial torsion that's dysfunctional, okay? So in other words, we'll see that a lot with pronating feet, or if somebody has a decreased dorsiflexion or hallux limitus, we'll see a lot of increased pronation associated with the foot, and that creates our torsional injuries at the knee. So in order to help correct this, what we'll do is grab at the tibia, grab at the thigh, and we're going to literally derotate, and I use that in kind of a quotation marks because we're really not mechanically changing the position, it's much more neurologic, but we're going to try and derotate the skin associated with that and have the patient squat again. If that is the one that gives her the greatest amount of pain relief, again, I'm always looking for a minimum of 50% reduction in symptoms just with this testing. 50% is my bare minimum. We're looking usually for something a lot more than that. But usually you'll find one of those is going to make the patient feel better. In this case, we're going to just give an easy one and just say she had a lateral tracking patella, and just blocking that lateral tracking made the patient feel better on a squat. Now, what we can do in order to start making this patient feel better is not just use our taping, but we can actually utilize some soft tissue treatments. The major thing is I use this with my patients all the time. It's like balancing out your seesaws. In other words, we may have a tighter muscle group than another. We always want to look basically from lateral, medial, anterior, and posterior, and we're going to just rebalance all of these things. So if I can have you bring this pant leg up as high as it'll go. We're going to have this patient basically expose as much of her leg as possible. And using our emollient and instruments, we're going to do what's called a neurologic reset, which is a very light treatment along all the soft tissues that are creating mechanical strains on the patella. And what I like doing is resuming the position that creates some of that dysfunction. So if she was having pain on a squat, what we're going to have her do is come slightly into our squat. That's perfect. And right from there, we're going to do our soft tissue treatment. Now, it's basically the weight of the instrument. We're not trying to create a lot of pro-inflammatory kind of response. All we're literally looking to do is create a hyperemia on the skin. A hyperemia lets us know immediately that we've stimulated the same neurology that will reset a muscle, by creating that vasodilation in the blood vessel. So same receptors that create the vasodilation are the same receptors that actually we're trying to stimulate that will do a reflex loop mechanism that resets the tone of the tissue and the spindle firing. And it just takes about a minute or two over each region. Now, the important thing to realize once we're actually resetting all of these tissues is that we still have this retinaculum that we have to deal with where we have an imbalance. That's one of the areas that we're going to be a little bit more aggressive, but we're also going to unload our patient. So in this situation, what we're going to do is we're going to let her unload the knee, and using our hand, we're going to slide the patella into the direction that we're trying to treat. So we're going to be using the lateral retinaculum here. We're going to slide the patella over. I'll take a skin tension and use my instrument to come right up underneath the patella. And we're going to do that same thing medially. So now we're going to push the patella medially, use a finger to pull down on the skin, and slip our instrument right underneath the patella. Now, this kind of a generalized treatment in itself usually creates a rather large reduction in symptoms on their provocative activity. So again, what we're expecting to see while doing something like this is she's going to go in her squat again, and it'll probably be at least a 50% reduction in symptoms. Usually it's a lot more than that with a simple tracking disorder. We'll have a retest. Patient should say, yeah, I'm feeling pretty good at this point. Doing okay. Come on back up. Now, we're going to clean off our patient immediately afterwards. Now, we can use anything from alcohol, biofreeze actually can be used to clean off the patient. I just tend to do alcohol on a towel. If I'm using biofreeze, I tend to use it afterwards. And then we'll show in a second how to do our taping for this. And in particular, we're going to just have her come up to the table now. And we'll just have her put her head on this side since it's the same knee. So with a patellar tracking disorder, one of the tape jobs that's so easy to do with these cases is basically a structural tape job associated with kinesiology tape alone. And what we'll do is we're going to show a couple of progressions on this. With the patellar tracking disorder, what we're going to do is break the tape right in the middle, separate the tape, grabbing the backing between our second and third fingers and the tape with the backing between our first finger and our thumb. And we're going to give at least that 50% stretch. Now with the exact stretch indicator, you can see that hexagon becomes in equidistant position. As soon as it's equidistant, you know you're at a 50% stretch. We want to make sure we're at least there. We might give it a little bit more. Make sure that you have the tape along the lateral border of that patella and just lay down in a C shape. And that's our easy tape job that we can do for tracking disorders. Now, if that, we can have the patient get up and do a squat again. If that's not enough, we can actually add to this. Again, we're always looking for that 50% reduction minimum. If it's not enough, sometimes using Tim Brown's AC tabs can give us just that little extra stimulation to create more of a mechanical improvement in the knee. And we can use that tab My tabs are being placed right at the medial, or the superior and inferior pole of the patella. And we're gonna just do that nice little pull again, right over the tab. Now, in most cases, this is gonna be a little bit too much, all right? This is only going to be utilized if on the squat test they haven't improved another 50% from our initial tape job. We can add in those tabs, create more of a vector pull associated with our leukotape. And again, this is going to give a much more rigid blocking on that squat to prevent the patella from actually moving laterally. But this is a simple way of handling some of our patellar tracking disorders associated with an imbalance in musculature in the leg, and using the taping to help assist mechanically as they're going through things like squats or steps.